Hey everyone, and welcome back. This is Nurse Eunice, and in tonight's video, we're going to cover tubes, lines, and drains. What you need to know as a new healthcare provider in order for you to provide safe care. Here's our introduction. Whether you're a new CNA, patient care technician, or someone preparing to enter the healthcare field, you're going to see a variety of lines, tubes, and drains when caring for patients. Some of these medical devices are commonly seen on adult medical surgical units, while others are used in more specialized units, such as critical care or step down. Your role is not to manage these devices, but to observe them, protect them, and report anything that doesn't look right to your nurse. And remember, when in doubt, always ask your nurse, not another CNA, for guidance. There are no bad questions when it comes to patient care. The more you understand what you're seeing, the more confident you'll feel, and the safer our patients will be. We're going to begin our review by talking about tubes, lines, and drains, or monitors that relate to the heart and the lungs. This is basic, you all. We're going to talk about the pulse oximeter, which you see in the lower corner of your screen. Usually that finger probe would show two different readings. It would show the oxygen saturation, and it would also show the heart rate. You all, the oxygen saturation can fluctuate, so it can be anywhere from 95 up to 100%. That is normal, and the same with the pulse, which could be 60 up to 100. But whether that is a sticker-like probe that you would attach to the finger or something that is made of hard plastic, which you can put on for short periods of time, this is what you'll often see for someone who needs their oxygen saturation, aka their lung function, monitored. Next would be the telemetry box. Yes, as a CNA, as a patient care tech, this isn't an EKG. This is what we use on the floor, but it has similar principles. It has wires, aka electrodes. The electrodes actually are labeled. So they're going to let you know whether you're placing this electrode on the right upper chest, the right lower chest. It is going to be labeled. So it's going to be easy for you to use. And it is connected to a telemetry box. And this remotely sends the heart's function to a remote station, which could be at the secretary station. And that is where your secretary or whoever your monitor tech is, they will be able to see your patient's heart rhythm. Not every hospital or nursing home would have the telemetry monitor directly in the room. Some have them in a separate area. But regardless, your job would be to place the telemetry box and the leads on the patient and to monitor them. So if they do have a monitor in the room, and let's say you see a rhythm that's kind of erratic, is your patient moving? Are they staying still? And based on what you see on that screen, it's going to let you know whether or not you need to alert your nurse. Now, at the time of discharge, you all, make sure you get these devices back because your facilities would have to pay for these devices and they're quite expensive. So yes, you put them on, you monitor the patient, you monitor what you can. If you haven't taken an EKG course, we're not expecting for you to tell us what the patient's heart rhythm is. We're just expecting for you to know whether or not a heart rhythm is present. Always check your patients. Let's go to the next one. Now we're going to be discussing oxygen delivery devices, and these are just a few. Remember, this is a review. It is not all inclusive. The image that has the infant or the child, that's a nasal cannula. And yes, adults, children, and infants can have a nasal cannula. This provides a low flow oxygen. Sometimes it's going to be connected to a plane of dry mouth. Let's go to the image of the lady who has on a blue gown who is nearest me. This could be a BiPAP or a CPAP. A lot of patients complain about having these devices on because they are not comfortable. Could you imagine being a CNA who has to figure out how to walk a patient to the bathroom who has a BiPAP on, and how are you going to feed them? Remember, you are not by yourself. There's a whole nursing team. So maybe this patient wouldn't be able to walk to the bathroom. Maybe instead you get a bedside commode. And maybe your nurse has an order from a doctor that says during mealtime, time, the patient can take off the BiPAP and put on a nasal cannula. So there are no definites in healthcare. We have to do what works best for that patient. And remember, they're still going to need oral care. Their face is going to be dry. That is when you can come in and give that extra support that you are so great at doing. The image in the center represents someone who has an endotracheal tube. So this is somebody who is intubated. Most times they're going to be unresponsive, or if they are responsive, it is just to pain. Maybe they can wiggle their fingers or blink their eyes. This machine, or this tube, would be connected to a ventilator. So the one that's in the center is more commonly seen in ICUs. Remember, you are just starting off. So I'm just telling you what these tubes are so that when you see them, it won't be like, oh my God, what's that? You're going to remember this video and say, oh, that's a patient who needs help with breathing. That must be an intubation tube. And maybe that huge machine that's connected to it is a ventilator. I promise you it'll make sense. Give yourself grace to learn all of this. These are pleurovacs. Pleurovacs are chest tube drainage systems. Why would a person need a chest tube? Maybe because of injury, let's say a car wreck in which a rib or a bone punctured someone's lung. So due to injury or to surgery, let's say someone had lung cancer and we had to remove some nodules, that patient may end up with chest tubes. In the image that you see here, this patient has 2 chest tubes. So that means that maybe chest tube number 1 is for the right lung and chest tube number 2 is for the left lung. Regardless, they are usually standing or they are mounted upright on the bed. If you see anything that looks abnormal, if you have any questions, you are to notify your nurse. You're not the only one taking care of this patient, but you're going to be the one who's turning them, who's in there helping them reposition, use the bathroom. And so it's going to be hard to maneuver patients when they have tubes and you're nervous. So the more you know, the better for all parties involved. Now we're going to discuss bowel and bladders. Let's see what tubes, lines, and drains that are commonly seen for bowel and bladder usage. We're going to start with the images closest to me. And so the yellow flexible tubing that's extending out of the urethra, whether it's male or female, that is called a catheter. What you will commonly refer to it as is a Foley catheter, but during your CNA test, it's not going to discuss name brands. So instead, it may say indwelling urinary catheter. That is a flexible tube that drains the urine from the bladder. Now, what's seen in the image is not real world. If we just have a tube that's draining urine and nothing to collect the urine, that is not only going to cause a huge mess, it's also going to cause an infection risk to the patient. We need a closed system. So whenever your nurse inserts a urinary catheter, most often it is automatically connected to a drainage bag. And so the drainage bag is what you see on the opposite end of the screen, and it has a urometer. So that means that you can really be looking at how much urine this patient's producing on an hourly basis. And then once that first chamber is filled, it will flow into the bag. Regardless, when that bag is halfway filled or at the end of your shift, you are to be emptying that bag. If it gets too full, it won't allow more urine to actually flow, which means that patient will end up retaining urine. And if the urine backflows, the patients can actually acquire urinary tract infection from the old urine. Now the image that shows the male with the leg strap. This one represents a condom catheter. So anytime we stick something foreign inside of a patient, they are at risk of a urinary tract infection. So what does a condom catheter do? Instead of actually putting something through the urethra to drain the urine from the bladder, there's a condom-like device that has adhesive that's safe for skin that we will roll onto the shaft of the penis. And that way, when your patient's incontinent, when they're urinating, it will just flow out through a flexible tube that's connected to the condom catheter into a bag that may be attached to their leg. So that is something you can see sometimes in home care with patients who are more mobile. So let's just go through a few more rules about the bags and also about a patient who has a urinary catheter. We have to keep the urine bag below the level of the bladder to prevent backflow. If for some reason you are troubleshooting it, maybe you don't see enough urine in the actual bag, you want to be checking for kinks. You want to make sure it's not wrapped around your patient's leg and that your patient's body weight is not obstructing the flow of urine. As far as the catheter insertion site is concerned, you're going to keep that area clean and dry. And now the last one is a mistake. It says observe the tubing on the leg. It means that you should be securing the tube on the leg. So yes, you want to secure it. Your facilities will usually have devices or tape that you can put on the upper thigh to help keep everything secure to prevent it from moving and causing injury to your patients. Next, yes, just like a colostomy, there is a urostomy. So a patient could have a stoma in which urine flows through. So let's think about somebody who has congenital birth defect and maybe they have a shortened urethra, or maybe there's a stricture, which is a really tight area. So instead of them urinating the normal way, their urine route would be bypassed and it will come through the skin on their stomach via a stoma. That is a urostomy. Say it with me, urostomy. The image of the funny shaped tube with a canister, that is a PureWick. I don't know of another way or another name brand, but a PureWick is what is used to wick the urine away. It's like a suction. And so that device will be placed against the woman's vaginal area when they are in the bed. And when they urine, it would, if you have it connected to suction, it would just whisk all the urine away. That is a PureWick, and that is common because, again, whenever we insert a catheter or we do something invasive, we increase the risk of catheter-associated urinary tract infections. And so things like PureWicks and you getting that patient to the bathroom more frequently would help reduce the risk of infections. If you're learning something, go ahead and give us a thumbs up in the chat. And next, we're going to talk about, of course, a suprapubic catheter. So let's talk about that person who had a birth defect, or maybe they have a neurogenic bladder, meaning their bladder is paralyzed. Instead of them having a traditional catheter that is in their urethra or their vaginal or their penile area, instead one that would decrease the risk of infections, UTIs, and allow them to have quality of life and maybe even have sexual activities would be a suprapubic catheter. Supra being above, pubic where the hair is. Okay, so suprapubic catheter is above their pubic area. And this is you won't see it too often, but if you do, it's usually in your younger adults. If you work in peds, you may see it in also your pediatric population. This image represents a stoma, and this patient has a colostomy. So remember we talked about a urostomy, which is urine. A colostomy means that part of the colon is protruding through the skin, and this would allow fecal matter to pass, and it's going to actually be captured in the bag. The stoma, whether it's a urostomy or a colostomy, the stoma or the part of the organ that's protruding through the skin is supposed to be nice and pink, a beefy red. If it's anything abnormal, you're to let your nurse be made aware. If you are required to change the dressing, to change the ostomy wafer, your nurse will teach you how to do so. What are you required to do? You're required to empty that bag, whether it's a urostomy or a colostomy, whenever it's 1/3 the way filled. Some of your facilities will give you a little bit of grace and say halfway, but again, no one wants this bag of urine or fecal matter just sitting in the bag for a whole 8-hour shift. So once there is a substantial amount, 1/3 to 1/2, go ahead and empty it. Now we're covering gastric tubes. And remember, this is just a brief overview. Your nurses, your facilities, you're going to learn so much once you're in a facility as a CNA or PCT. I just want to give you that good intro. All right, so for gastric tubes, we have a couple of devices. And I'm just waiting for my screen to catch up. Just bear with me. One, it says nasogastric tube. Two says nasoduodenal. And then three is nasojejunal. Look here, we don't say those. If it's going through the nose, we're going to say NG tube or nasogastric tube. Then for the stomach, it's called a gastronomy tube, or you may hear us call it a G tube for short. If it's going through the jejunum, we're going to call it a genostomy tube or a J tube for short. What do you need to know as a CNA? If someone has an NG tube or a J tube or a G tube, is it connected to suction because we are clearing out the bowels and the bladder, or are we actually going to be having food being instilled through a pump? And so in the image right above my head, that is what we would usually see in a facility, and your nurse would set it. She would hang the tube feeding, and then slowly over a few hours, the patient could receive nutrition. Right now, they're not able to eat and drink for whatever reasons, or they're not able to eat and drink enough to support life. And so that's why they will have their tube feeding. And a tube feeding, whenever a patient's eating, think about it. When you and I eat, we sit up straight to prevent the risk of aspiration. However, when someone has a feeding tube, whether it's a nasogastric tube, a G tube, or a J tube, we don't want them sitting upright too long because that's going to cause them to develop a pressure sore. So in most of your facilities, they have to be upright at least 30 degrees during their tube feeding. And you can't lay them flat to give them a bed. You can't lay them flat to give them a bath and or to reposition them as long as the tube feeding is actually infusing. So what would you do? You're going to ask your nurse for assistance and or follow your facility's protocols, because not all facilities allow CNAs or patient care techs to touch the pumps. You would have to make sure that's part of your scope of practice. All right, our next slide, team. We're going to discuss intravenous and central lines. So these are ways for patients to receive fluids, medications, and maybe blood products. The image of the human hand shows a peripherally inserted venous device or IV. And so this is what you'll commonly see in your facilities. However, the other images shows those central lines, so a central venous catheter. This means that this patient, maybe their veins have blown, they need, more antibiotic therapy, and the antibiotics are really strong and they're irritating to the veins. So we don't want to put them through the superficial veins, such as those in the hands or the arm. And so that is when the patient would have a central line. What do you need to know? It's more than likely going to be attached to something. So when you turn this patient, when you get them up and go to the bathroom, if they have too many lines and tubes, don't do it by yourself. Ask another CNA for help if allowed at your facility, but you can also ask your nurse. Remember, teamwork matters, especially when your patient has lines, tubes, and drains, because if you do anything, even if it's just an innocent mistake, you could rip or pull that line out. A patient could step on their catheter. You can cause an injury to your patient, and we know you don't want to do that. This is the image. So those intensive care, those critical care nurses, they deal with trauma patients. They deal with patients who are super sick, who may have the need for multiple IV fluids going simultaneously. That little hand vein cannot tolerate all of those fluids. That is why a patient would have a central line, and they may have multiples because not all medications are compatible. So if your patient has a central line and then they have the peripheral IV and they have a portacath, just know that that patient has been through some things. Be extra patient with them. They've been sick for a while, and that they need to have all of those lines in order to support their health so they can get their medications. We're almost done with our review, team, and it's almost time for practice questions. Next, we're going to talk about drains and wound care. So, two of the common drains you will see, and these are not all of the drains, these are the common ones, will be a hemovac and a Jackson Pratt. What's the difference? The hemovac is more of an accordion. So, it's something that's going to be compressed and it allows more fluid, more blood to drain from a surgical site. So, a hemovac would be for, the surgeon would decide which one is best for that patient. But the hemovac would allow up to 500 mLs of fluid to be evacuated. And again, you would empty that hemovac whenever it is half filled. And once you empty it, you have to compress it all the way down to keep the negative pressure so it can continue to evacuate. So think of an accordion. Once that accordion is stretched out, we have to do something to get it back together, to push it back down. And in order for you to push it back down, you drain it, push it down, cap it back off, and it's going to repeat that process. Now, your Jackson Pratt, which we don't say that, we say a JP drain. Your JP drain holds 100 to 200 ml. So that means it's going to be a smaller quantity of fluids that are evacuated from the body. This is the one that you're going to see oftentimes after a surgery. And yes, your job as a CNA or a PCT would be to empty the drainage, to monitor it, to make sure you document it, and then you have to compress that bulb back so that more fluid can drain out. I know that's a lot for you to learn, but you can do it. I'm so proud of you. This is a wound vac. So there's going to be all types of dressings your patients have. I'm not talking about the basic dressings. I'm talking about things that have lines and tubes and pumps and vacuums, because you still have to provide patient care. Patient has a wound vac. They still may not want to use a bedpan. They may want to get up and walk to the bathroom. So what is your concern as a CNA? You always check that order. What are their activity orders? Okay, the activity order said they can walk to the bathroom. Maybe you can recommend a bedside commode, but no, this patient refuses. They want to go to the toilet. They don't want to be having a bowel movement at their bedside. So now you have to maneuver that vacuum, make sure they don't, disconnect their wound vac. You're going to follow the protocols at your facility, but there's a lot that goes into it. And if you look at this patient's feet, what's missing? That's right. They have to have safe footwear before you get them out the bed. So just because a patient has a drain tube or a line doesn't mean they're bed bound. What it means is that you have to pay special or close attention when you're assisting them out of bed. And again, maybe they shouldn't be going to the bathroom. Maybe they should be going to the bedside commode instead. That may be safer. When in doubt, you know who you're going to talk to. You're going to talk to your nurse. We've covered a lot so far, and it's almost time for our review. I want to tell you about our partnership, Florida Training Academy's partnership with CareerStep. And so we do offer the online patient care technician program, which includes phlebotomy, it includes EKG. Best of all, it doesn't matter where you are in the United States. The career advisors at CareerStep will work with you. The course fees also include a certification exam, which is a national examination. The differences between a PCT and a CNA is, it's a basic caregiver versus a PCT. That's the caregiver, that's the CNA who works at the hospital level. So if you want to do more at your CNA license, we highly recommend that you go to floridacareeracademy.com and speak to one of our care advisors at CareerStep and tell them that Nurse Eunice sent you. We've been adding so many of our downloadables, our freebies for our channel members. So if you are a channel member and you're watching this, I want to say thank you for your support. Again, most of these presentations that we do take about 4 hours. I have to do research. I have to make sure I have the correct photos, etc. So even you joining at the Study Buddies level for $4.99 per month, it helps us to create this content, to get these videos out. And so we appreciate you. If you want to join our channel, just go to our YouTube channel, if you want to join the membership. You can click subscribe if you haven't done so. If you're already subscribed, you click join, and then you too will be able to see our member only downloadables, and you can get your freebies today. And this is the freebie that is going to be added tomorrow. It is about what CNAs monitor versus don't touch, members only. And so pretty much it's telling you it's going to be discussing your scope of practice, what you can and cannot do. So if you like freebies like this, infographics, and much more, go ahead and join our YouTube membership today. Lastly, before we get to our practice test, let's talk about, yes, our CNA study guide. So many of you all have messaged us to say that you have the study guide and that you love it. It took me months to create it, and I am so proud of it. I know it's going to help you pass your examination, and no, it is not just for Floridians. While it is aligned to the Florida standard, it is for anyone who wants to learn the basics of healthcare. And so it's only $21.99 on Amazon, and you can also find it at nurseunis.store. All right, let's start with our first question, everybody. I hope you're ready. Number 1, which of the following is not a function of a colostomy? Is it A, to remove waste from the body, B, to divert stool from the rectum, C, to administer medication directly into the bloodstream, or D, to allow the intestines to heal after surgery? Go ahead and put your answers in the chat. Yes, that is the correct response. Revealing the answer in 3, 2, and you have it. The response is C. A colostomy is a surgical procedure that involves creating an opening in the abdominal wall through which stool is passed out of the body. It is not used to administer medication directly into the bloodstream, so it allows the stool to come out. Question 2. What is the primary purpose of a Jackson-Pratt or JP drain? We just discussed this. Is it A, to deliver medications directly into the wound, B, to remove excess fluid from a surgical site, C, to provide nutrition after surgery, or D, to measure urine output? I am so proud of you. Excellent. I'll reveal the answer in another 3 seconds. If you chose B, you have it. That is right. A JP drain, which is that bulb type drain, is used to remove excess blood and fluid from a surgical site to reduce swelling and promote healing. You have it, team. Question 3. On post-operative day number 3, what type of JP drainage is most commonly expected? So on day 3, what type of drainage do you expect from the JP drain? Would it be A, bright red blood, B, large amounts of thick pus, C, smaller amounts of lighter colored drainage, or D, no drainage at all? Give yourself applause. Yes, we expect a lighter color on day 3. So it's going to be C. By day 3, drainage usually decreases in amount and becomes slightly lighter as healing progresses. So yes, every day you as a CNA, you're monitoring the output, you're documenting it, and it should get better and better and better. What does that mean? The color should become lighter and lighter. There should be lesser fluid being drained from that surgical site so that by day 4 or day 5, the doctor would come in, do his evaluation, and then determine whether or not that drain can be removed. And I know most patients are so relieved when their drains are removed. And they're also relieved when they see the coloration improved. So great job, team. Number 4. What is the purpose of a nasogastric or NG tube? A, to deliver nutrition directly into the bloodstream. B, to drain excess fluid from the lungs. C, to administer medication through the nose. D, to remove gas and fluids from the stomach. This one is tricky. Nasogastric. Break down the terminology. The prefix naso, what does it refer to? The suffix gastric, what does that refer to? Yes, referring to the nose and the stomach. So if you chose, no, we're not administering medication through the nose. If you chose D, you have it. And that is an example of a nasogastric tube. An NG tube is inserted through the nose and into the stomach to remove gas and fluids, as well as administer medications or feeding. So if a patient's really sick, they come in, they get their NG tube, be connected to suction. It's going to pull off all that bowel, that green drainage. Maybe they overdosed on something. We're going to pull out all the toxins. And then once their stomach has had a chance to rest, we can gently start tube feedings. But the primary purpose is not for medications, because if a patient could swallow a pill, we wouldn't have to put the nasogastric tube down. So the primary purpose for an NG tube is to remove the stomach contents. Number 5, which of the following actions is most appropriate when caring for a patient with an NG tube? Is it A, elevating the head of the bed to prevent aspiration? B, securing the tube to the patient's face with tape? C, pulling on the tube to reposition it? Or D, administering medication through the NG tube without checking placement? That's right. This one should be super easy for you all, because if you've watched any of my videos, you know that a CNA who has not attended another course, who is not in med aid or med tech, cannot administer medications. So by default, the answer is not D. I know it's tricky. I know that you want to put tape on a patient's face, but what if they have thin skin? Is that within your scope of practice? Should you be making those decisions without the nurse? So the answer is also not B. Yes, it is A. When someone has an NG tube, we have to keep the bed elevated, usually about 30 degrees, because it helps prevent aspiration of gastric contents. Remember, they have a tube, so they epiglottis, the part that the flap that prevents backflow of fluids from the stomach into the lungs. Because they have that tube, that flap is open. And so, yes, fluids can travel up and they can enter into the lungs when someone has an NG tube in place. So you sitting their head of the bed up helps to reduce the risk of complications, and it also helps to reduce the risk of aspiration. They don't have to be set all the way up. They can be set up about 30 degrees so they're comfortable. Number 6, which of the following is a potential complication of an indwelling urinary catheter? A, increased risk of hemorrhoids. B, increased risk of urinary tract infections. C, increased risk of skin breakdown. C was decreased risk of skin breakdown. And then D is decreased need for frequent toileting. What is a complication of an indwelling urinary catheter? So many correct responses. Yes, a complication when we are inserting something that is abnormal into someone's urethra. A complication would be B, a UTI. So indwelling urinary catheters can increase the risk of urinary tract infections due to the introduction of bacteria into the urinary system, which is why we always try to perform the least invasive techniques first, such as taking your patient to the bathroom more frequently, giving them a bedpan. Notice how we don't use a whole bunch of adult briefs or diapers, because that traps moisture against the skin and increases the risk of bed sore. Question number 7, which description best matches serous drainage. And I want you to get pen and paper. I want you to write this down. You have to know these terms because when you're documenting, you have to let your nurse know what color the drainage is. So when you say serous, what are you referring to? Is it A, thick, yellow, and foul-smelling drainage? B, green with clots? C, bright red and heavy? Or D, clear or pale yellow and watery? Right? You document the patient has serous drainage, and your nurse comes to you and said, hey, what does serous mean? Which of the answers would you select? Yes, it is D. So serous drainage is clear or pale yellow and is commonly seen in normal healing wounds. So that's what you expect to see. So now we have it broken down. Sanguineous is red, so that could be dark red blood. And then serous sanguineous is a mixture of blood plus the serous, the yellow fluid. So it could be separated a little bit in the bulb where there's more yellow up top. The blood will be heavier, so the blood products will be towards the bottom, or it could just all be serous, which is yellow. Purulent is always a concern. So if you see something looks thick and discolored, if it has a funny smell, remember, if you see something abnormal, you notify your nurse. So let's go through those. Serous sanguineous, what does that mean? That's right. It has some blood, but it also has some of that yellow or clear fluid. Is purulent good or bad? That's right. Purulent is a sign of infection. All right, question number 8. What is the purpose of an endotracheal tube? A, to drain fluid from the lungs. B, to deliver oxygen directly to the lungs. C, to monitor heart rate and rhythm. D, to administer medications into the bloodstream. Revealing the correct response in 3, 2, and 1. That's right. When a patient has an endotracheal tube, the answer is B. It is inserted through the mouth into the trachea to deliver oxygen directly to the lungs and to assist with breathing. So this is when oftentimes you see your patient who is connected to a ventilator, a machine that has different readings and different functions to help a patient who's struggling to breathe better. Question 9. Which color of drainage is most concerning and should be reported? A, clear yellow. B, light pink. C, thick green with color. Or D, small amount of bloody drainage. Which is most concerning? I know this one's tricky. If it's a small amount of drainage, bloody drainage, I'm not as concerned about that as I would be about C. Oh, I know this image is, look, as a nurse, I can do blood, I can do bowel, I can do emesis or vomit, I can do urine. What I cannot tolerate is mucus. So I am not fond of this photo at all, but thick, green, and foul-smelling drainage, whether that's mucus, it could be the drainage from a wound. Anything that is green most likely indicates infection. Number 10, which of the following is a first sign of a blocked urinary catheter? Is it A, increased urine output, B, pink or red urine, C, pain or discomfort in the bladder, D, decreased urine output? I did not expect for any of you to get this one wrong, and I was absolutely correct. So the first sign of a blocked urinary catheter would be, drum roll please, D, there wouldn't be any urine in the tube. So a blocked urinary catheter can result in decreased urine output as the urine is unable to drain properly into the bag. So your other option, which was C, pain or discomfort in the bladder, usually is not a first sign. The first sign was decreased output. And because that urine was being trapped or backing up into the bladder and urethra, that is when a patient experiences pain. So number one, first would be decreased output, followed by pain or distension or discomfort in the bladder area. And I'm so proud of you all for studying with me. Yes, so 11, we're going all the way to 25. How often should a colostomy bag be emptied? Is it every 6 hours, once a day, every 12 hours, or as needed? And I just gave you this answer, so I expect you to get this right. How often should a colostomy bag be emptied? That's right, as needed, because if your patient just got through eating some beans for breakfast, I'm sorry, by lunchtime, it may not be all the way filled with fecal matter, but it could be filled with gas. So you empty them as needed. Here's your rationale. A colostomy bag should be emptied as needed or when it's halfway filled or at the end of your shift, depending on the individual's bowel habits and volume, the quantity of the stool in the bag. 12, which of the following actions is appropriate when cleaning a stoma? Remember, that's the red, beefy part of the colon or the intestines that's protruding through the skin. So which of the following actions is appropriate when you're cleaning a stoma? A, using sterile saline at room temperature. B, use warm water without soap. C, use warm water with mild soap. Or D, use a 10 cc syringe with saline to irrigate the stoma. So it's kind of like pressure washing or power washing the stoma, which is going to be best for you and your patients. That's right. When you're cleaning the stoma, we're going to be as gentle as possible. And it's going to be, let's go back and look. It is not, yes, it's B. I do apologize. We normally do not put soap on the stoma because it could be irritating. So it's B. We're going to clean the stoma gently by wiping with warm water. Aggressive cleaning can cause bleeding, and we oftentimes do not use soap. You'll find what your facility's policies are. And then we want to try to avoid any oil-based soaps or perfume products as they may leave an oily residue which may prevent the pouch from sticking to the skin. 13, what should be done if an intravenous or IV line comes out while you are turning a patient? Is it A, turn the IV pump off and then notify the nurse? B, monitor the patient and immediately call for the nurse? C, clamp the IV tubing to stop the flow of fluid? Or D, do not tell anyone so that you do not get into trouble? Patient safety is always the priority. It's not about you getting in trouble. It's to make sure that that issue does not happen again. So the correct response if a patient's IV line comes out while you are turning them, it's going to be B. All right, you're going to have to make sure you notify the nurse and you're going to apply direct pressure because if IV comes out, the site could start to bleed. And so it's best to ask for assistance with turning whenever possible, especially if a patient has multiple IV lines and a catheter, because it's going to help prevent the lines from being pulled out or dislodged. 14, a patient has a gastric tube feeding and is scheduled for a bath. How does the CNA know whether the pump can be paused? A, yes, pause it automatically. B, ask the nurse in charge. C, ask Nurse Eunice on YouTube. Or D, follow your facility's protocols. Why does this even matter? Your patient has a gastric tube feeding and they need a bath. What position do you bathe someone in if they can tolerate it? You're going to lay them flat. You can't lay this patient flat because they have a gastric tube feeding. That would put them at risk of aspiration. So what do you do? What do you do? What do you do? Correct response is D. You need to know what your facility's policy states because you are governed by the Nurse Practice Act. Usually the Board of Nursing sets the rules for CNAs, and we don't want you doing anything outside of your scope of practice. Do not expect the nurse to know all of the rules pertaining to CNAs. It's up for you to know also. So the best answer would be for you to follow your facility policies regarding tube feeding management. And that would mean that if allowed at your facility, whenever you're bathing a patient, you could pause the feeding so that you have enough time to lay them flat, and perform your care. And then once your care is done, you can resume the feeding and sit them upright. Again, that does not happen at every facility. So I need for you to know what your facility and company policies are. 15, which of the following is an appropriate method for securing an indwelling urinary catheter? A, taping the catheter to the patient's leg. B, using a catheter stabilization device. C, securing a catheter with a tight bandage. Or D, inserting a catheter deeper into the bladder. Which is appropriate? I know this one's tricky, but some of you have it. It is B. You don't see it too often. It may go by the term stat lock. A lot of you all want to use tape. I totally understand. But the reason why it's B is because we should be using a catheter stabilization device, such as a stat lock, because it helps to secure the catheter in place without causing undue pressure or discomfort on the patient. 16. A CNA notices a JP drain bulb is no longer compressed. What does this indicate? A, the drain is working correctly. B, the wound is infected. C, the drain has lost some suction. Or D, the drain should be removed. All right, giving you about 2 more seconds to put your answers in the chat. All right, so if that JP drain bulb is no longer compressed, that is C. You're going to have to know that that means that the bulb has lost its suction and right now it's not working. So you can go and you can try to compress it. That should be within your CNA or your PCT scope of practice, and then just monitor to see if the situation gets worse or if it improves. Question 17, what should a CNA document after emptying a drain? A, only what is emptied. B, colored amount, such as how much urine or fecal matter is in a container. C, time, date, color, and amount. Or D, surgical technique. Revealing the correct response in 3, 2, and yes, everybody has it. It is C. So accurate documentation includes document the time, date, color, and amount. That's right. So if you're on day shift, it's going to be from 6 a.m. to 6 p.m. You would document mostly a.m. times until after 12 noon. If you need help with military time, how to convert it, don't forget that we have that information in our new CNA study guide. It is your number one resource to pass the CNA exam in 2026. We're almost done with our practice questions, team. Question 18. Which tube is most associated with nutrition delivery? Most associated. Is it A, Foley catheter, B, abdominal tube, C, JP drain, or D, NG or G tube. So NG stands for nasogastric. Yes, yes, yes. Most associated with nutrition delivery. You all, I tricked you. To my knowledge, B is not an answer. And then none of the others are associated with delivery. So a catheter drains, a JP drains, and then B was just made up. So process of elimination, the answer must be D. That's right. An NG or a gastric tube is placed in the abdominal area on the left, so where the stomach is, and we usually utilize that for enteral or feedings that bypass the mouth. So when someone has a gastric tube, you may hear it being referred to as enteral or enteric feeding. That just means that you go to the designated area and you get the tube feeding that is prescribed for that patient. I know that sounds like a lot, but I promise it's going to make sense to you shortly as soon as you pass your CNA test and get your first job. 19. Why is it important for CNAs to understand tubes, lines, and drains? A, to perform medical procedures. B, to replace the nurse. C, to recognize any problems early and keep patients safe. And then D would be to reduce charting. Why do you have to understand tubes, lines, and drains? Reveal the correct response in 3, 2, and yes, it is C. CNAs play a critical role in early detection, safety, and communication. Question 20. Which of the following actions is appropriate when caring for a patient with an intravenous pump that keeps alarming or beeping? A, press the silence button on the IV pump. B, ignore the beeping. C, inspect the patient's IV site. Or D, tell the patient to straighten his arm. Which action is the most appropriate when caring for a patient with IV therapy whose alarm keeps beeping? All right, so the correct response is C. We're going to inspect the site for redness, swelling, or tenderness. It could be a sign of irritation, inflammation, or infection. And then you're going to notify the nurse immediately if any of those sites appear abnormal or if the alarm does not automatically stop when the patient straightens the arm. Great job, team. 21. Which of the following actions is appropriate when caring for a patient with an indwelling urinary catheter? A, emptying the drainage bag when it's half full. B, keeping the catheter tubing coiled on the bed. C, disconnecting the catheter from the drainage bag to empty it. Or D, removing the catheter daily to clean it. Which is appropriate when caring for a patient with an indwelling urinary catheter? Yes, the appropriate response would be A. We're going to empty the drainage bag when it is half full because that helps to prevent backflow of urine into the bladder and reduces the risk of infection. 22. What is the purpose of a suprapubic catheter? A, to irrigate the bladder. B, to administer medications directly into the bladder. C, to measure urinary output. Or D, to drain urine from the bladder. What is best, team? What's the purpose of a suprapubic catheter instead of a regular catheter? Revealing the response in 3, 2, and yes, it's D. So it still drains the urine from the bladder, but it allows more mobility, more quality of life, and less UTIs. So a suprapubic catheter is inserted into the bladder through a small incision in the abdomen to drain urine when the normal passage through the urethra is obstructed or unavailable. 23. What does it mean to keep a drainage catheter in a dependent position? A, the drain should always be hanging on the hook provided. B, the drainage bag should be below the level of the bladder. C, the drain should be attached to the suction wall. D, the drain is dependent on being emptied by the CNA every shift. I hope you are as proud of you as I am. So yes, whenever someone has a drainage bag that is in the dependent position, that means that the bag is going to be lower. It's going to be going towards the foot. And so position the bag below the level of the bladder and also towards the foot of the bed. And that's going to help to prevent the backflow of urine. 24. A CNA accidentally knocks over a patient's chest tube drainage system. We refer to that as a pleurovac. What should the CNA do first? A, sit it upright and try not to kick it again. B, reconnect and reset the system. C, clamp the chest tube immediately. D, immediately notify the nurse and assess the patient. Think about your assessment as a CNA. It's getting them into a comfortable position, doing the vital signs. So usually you all do not utilize a stethoscope. That is the RN or the LPN's role. Yeah, so if a CNA accidentally knocks over a patient's chest tube, look, just standing up isn't enough. We need for you to get that nurse into the room. A knocked over chest tube system can affect lung re-expansion and pressure. The CNA should assess the patient for breathing and distresses really quickly, about 5 to 10 seconds, and then notify the nurse immediately. So you can literally press your hand on the code button and just go through and look at your patient. How are you breathing? Do you have any pain? Ask those basic questions. CNAs do not reconnect or reclamp chest tubes. That's not within your scope of practice. 25. What is the purpose of a rectal tube? A, to drain excess fluid from the lungs. B, to contain loose bowel movements. C, to contain formed bowel movements. And then D, to measure intra-abdominal pressure. What is the purpose of a rectal tube? Revealing the correct response in 3, 2, and yes, a rectal tube is B. It's inserted into the rectum to prevent soiling in critically ill patients with diarrhea. So we're trying to collect that stool that's just flowing everywhere. It prevents infections, but it also allows our staff members to take care of patients who are truly sick. So you don't have to be so nervous when you take your test. We have the steps right here. Yep, step 1 is preparation, gather your equipment. Step 2, whenever you collect the urine, remember there has to be a bed pad or something beneath or a napkin beneath the actual graduate. And then 3, you're going to bend down to eye level to read the measurement. You can't hold it in the air like I did on one of the previous photos. That would cause you to be monitored more closely and possibly fail your examination. And then don't forget to clean everything up. And when we're cleaning, we do not pour anything into the sink. We pour it in the toilet. And then finally, take off your gloves, wash your hands, and document. So yes, that measurement, this form is going to be in our portal on our YouTube store. So you can go ahead and sign in as a member and you can download this and the other freebie today. And that's it, team. You did such a great job. You have now completed your review of tubes, lines, and drains. And if you'd like to see more of our content, if you want to see our CNA skills video, you can just scan the code that is on the screen. You can go to our YouTube channel, or you can also go to fltraining.com. We appreciate you. We thank you. And guess what, you all? Remember that caring CNAs become caring nurses. So you're doing things the right way. You're learning how to communicate, how to work with patients, family members, and doctors. And you are going to be an amazing caregiver. Thank you for watching, everybody. We'll see you in the next video.